So I know you just are really excited to be together and you want to talk, but you can, if we get finished with this, you can talk without me being around.
Or me.
Right? So it's probably more fun to talk without your teacher around. So we're going to talk about pain and opioids. There were some slides in here I wanted you to look at before class, and I wanted you to watch videos. Did anyone do that? Anyone have time?
Videos. Go you.
And physical dependence. Remember that you need to be exposed to a drug over time in order for tolerance to develop. However, just because you're exposed to a drug doesn't mean you will develop tolerance. And we used the example just a few minutes ago where maybe a patient was suddenly having an increase in pain, increase in breakthrough pain, for instance, even though they've been taking the same medication and even though they haven't suffered an additional injury. Physical dependence is when you develop physical symptoms like nausea or vomiting when there's discontinuation of a drug. So your body has adapted, your brain's adapted to having that drug on board. And when you don't have it on board, you have adverse effects. And so there's a drug called Effexor. It's an antidepressant. Anybody heard of that? Selective norepinephrine reuptake inhibitor. It has some adaptation in your brain affecting the norepinephrine reuptake. And if you stop taking the drug, within 24 to 48 hours, you start having adverse effects because the body's used to the drug being there. And when it's not there, it responds adversely and you become nauseated, jittery, shaky, just like you were coming off of opioids. Question?
So tolerance takes time to develop. Does physical dependence take a good amount of time as well, or does that happen like within?
So both of those things are going to take time to develop with adaptation. So probably over at least 3 to 4 weeks before you get therapeutic effect with CNS drugs. So then we don't know the exact timing for tolerance or physical dependence. It depends on the person, but it will be over time. Well, you can become physically dependent on something that's not addictive. So the example of Effexor, that's not a drug you can become addicted to. You don't get euphoria from it. There's not a recreational use for it, but your body still adapts to it, and withdrawing the drug causes symptoms. Okay, so it's kind of that recreational piece might be the difference. Oh, the link didn't show up. It says watch this video and it's not linked. So you guys can watch those at home. This is the slide where it had, I want this to go away. It's not going away. Here we go. Talking about the A delta fibers and the C fibers. So the A delta fibers are myelinated fibers. If a nerve cell is myelinated, the nerve impulse travels down it very quickly. It's important to know. These kinds of fibers produce a sharp pain versus a dull pain if you're affecting the C fibers. Okay, so this is kind of an academic knowledge, right? You don't go into a patient's room and talk about the kind of fibers that are being affected. But it's important for you to understand this because when we talk about drugs, we'll talk about what kinds of pain it affects, right? So if your patient has a dull and achy pain, you might treat it very differently than a sharp and burning pain. Okay, so a little bit of this is academic, but some of it is relevant to your actual practice. So I'm going to let you watch these videos about perception and modulation. All of these pain impulses have to do with nociceptive pain. The only thing I'll mention about neuropathic pain is that it affects the nerve endings and not tissue injury. I'm focusing only right now on nociceptive pain or tissue injury, and tissue injury that could be visceral or somatic. So visceral pain is what kind of pain? like organ pain. It's a deeper pain, a duller pain. People who say they have a heart attack, for instance, they say it's a heavy pain. There's an elephant sitting on my chest. It's a crushing pain, that kind of thing. But as someone who has, let's say, pleuritic pain, so the lining of their lungs is inflamed, that's a sharp pain. It's worse with a deep breath. It's stabbing. Okay, and so you can assess patients like that, and you can, well, if it's the lining of the lungs and it's sharp and maybe it's a stinging pain, I know that it's not an organ, right? Because it's sharp and stinging. Organs are dull and that heavy weight. Okay, so it helps you become selective as you're asking your patient what's going on, so you can determine the best way to treat them. Is that making sense? Are you sure? Because I got a little rambly. Good? Okay. So this class focuses on pharm, right? Because it's called pharm. But there's non-pharm ways to treat them. And so some of the things you're going to do with your patients is use the non-pharm stuff. So when a patient came into the ER and they, were playing basketball and it looked like they broke their ankle, before I gave them morphine, what did I do? I probably compressed it with our ACE wrap, the RICE acronym. I rested it, I iced it, I compressed it, and I elevated it. Then got an x-ray, then got morphine or whatever on board. Okay, so those physical interventions are important. Sometimes when you're taking care of patients in the hospital, even though there's pain medication ordered, there may be a gap in time between the time the patient needs the medicine and they're available to have it, right? And so what can you do to help that patient get through that period of time? So distraction might work, especially with pediatric patients. Kids are awesome with pain because either they hurt or they don't hurt. They don't malinger, right? They're not sitting around thinking, I want you to feel sorry for me. No, they want to get up and play. So when kids are hurting, they're hurting. When they're better, they're better. Adults are a little more difficult because when we hurt, we know it's getting ready to come back. We have learned that response, that it will return, and we kind of malinger a little bit and need some distraction. Okay? Teach people to use guided imagery. Think of a beach, whatever, watch TV. Don't judge people if they can watch a basketball game without pain, and when the game goes off, they have pain, because what just happened? They were distracted. They had cognitive distraction away from the physical sensation. Okay, so it can actually happen. It can be frustrating. If you're the nurse taking care of them, just try to be non-judgmental and don't kind of adapt to the mean, right? Because have you been around nurses who don't think patients' pain is real yet?
Always.
Right? Some people have been around that. So you don't want to be that nurse. You might feel it inside, but try to contain that and be very objective about the pain, right? Because it's the patient's perception is what it is. So make sure you know a little bit about the non-pharm ways that you can do relief. Okay, so here's the meat of what we're going to talk about. What does the nurse need to do? So we're going to use the framework of the nursing process with assessment, diagnosis, planning, implementation, and evaluation. And so as you're going through this, think about situations that you've been in where your patient said they've had pain. And so has anyone had a patient with pain in the clinical? What kind of pain?
Can I tell you what she had?
Yeah.
She fractured her ankle, so she was having pain after rehab.
Okay, so she had nociceptive pain, so it was tissue injury, right? So what kind of pain did your patient have?
She had throbbing pain across her chest.
Oh, throbbing pain.
Yeah.
So what kind of pain is that? It's probably still nociceptive pain, right? Because I gave you the choices of nociceptive and neuropathic. So is it neuropathic? It doesn't sound like nerve pain. So it has to be nociceptive, right? So it's somatic pain probably. Okay, so as you're thinking about those patients, envision them in your head. What questions did you ask them? What is your pain level? That kind of thing. Go ahead.
Is throbbing relative to where the pain is? Because I could have throbbing in my chest, but also I've had throbbing in my finger if I jam it in a door. So
the throbbing typically is the feeling of the pulsation in the area. And so if you know, you could have it anywhere. You would have it in your chest more if you were having maybe anxiety or palpitations. But, like you said, if you jam your finger in the door, you're still going to have throbbing. And it will get worse with it down low, right? So if you have anything throbbing, you elevate it so you feel the heartbeat less or the pulse less.
Did you say earlier that the like elephant on the chest, the acne, was that also nociceptive then?
It is also nociceptive, but it's a visceral versus the somatic. Yeah. Okay. And so we're going to think about the ways that we want to treat pain. So is it thinking about sharp pain? Do I consider sharp pain very urgent or dull pain very urgent? That's a trick question. It depends on a lot of other situations, right? So there's no one size fits all, but within the realm of looking at a patient, I'm going to take into account their pain intensity. That's their pain scale. I'm going to take into account the way they look, their nonverbal communication. Do they look like they're in pain? Or do they not look like they're in pain? Some people have physical response to pain. So your pulse goes up, your blood pressure goes up, you become diaphoretic, you're sweating, you're pale, you look like crap, right? Those people, they're in pain. You can tell they're in pain. Other people don't have that same response, but it doesn't mean they're not in pain. It means you maybe need to assess them in some other ways. So in health assessment, you learned the old CART mnemonic, right? So what does that stand for? Onset, location.
Associated manifestations, relieving or aggravating factors, and treatment.
Somebody's got this one down, right? So you're going to ask that for every patient that you're taking care of. So when you come out of you're in clinical and you come out of the room and you say, oh, Mrs. Room 545, because you can't tell me the name because I'm not, whatever. Mrs. 545 has got pain and I need to give her medicine. Right? What am I going to say? What do you say to me?
Where's the pain?
Yeah, like, that's not enough information. I can't just hand you over a vial of morphine because you say, there's some pain. I need more information. You need to make sure you're treating your pain appropriately. The diagnosis part for you is a little bit difficult. Usually it has to do with acute pain related to injury, that kind of thing. I'm not super interested in that diagnosis that you're going to work on in clinicals. I'm so much more interested in your good assessment and your good plan to treat it, okay? So know what you're talking about there. Your plan should include some farm treatment, but also non-farm treatment. Okay, so non-farm treatment could be, the ice and things like that. I put up here pillow splinting. That's really good for abdominal pain, or if you've had somebody with abdominal surgery, they're having a lot of pain. If they hold onto the pillow and hold their belly, when they move around, it stabilizes it and they have less pain. You can teach your patients to do that. It's very helpful. And then after you've given somebody pain medicine, what do you do about it?
Check, make sure that they're okay.
Always evaluate, right? That's what I'm hearing. Always evaluate. Evaluate. Next is the good stuff. We're getting into opioids. So these are drugs that relieve pain without loss of consciousness. And that's, so what drugs would cause pain relief with loss of consciousness? Generally anesthetics. So if you're putting someone to sleep, so to speak, that's what we're doing, right? These are the most effective pain relievers that we have available. Of note is the term opiate refers to the compound within opium, not really the drug. So when you're talking in medical terms, we'll talk about opioids and not opiates. So some of that's just a FYI for you guys. These are the receptors. You guys already know about the receptors. You just tested on them, so hopefully you know what's going on. We're going to focus on opioid agonists, which have a strong mu effect and a weak kappa effect. We're not going to focus too much on the partial agonist-antagonist. They're not very useful. You don't see them much in practice. I'd rather you use your time for something else. But I do want you to focus on the opioid antagonist. So that would also work on the mu receptor. So your drug of choice, your prototype is morphine. Morphine is used for moderate to severe pain. And how would you classify moderate to severe pain? How would you know what it is? Does someone ring their call bell and say, hello, I'm having moderate pain? What do they say? What do they say? Absolutely. So let's do a pain scale. If I call you up and I'm like, I have a lot of pain, you say, oh, I'm sorry to hear that. Can you tell me your pain on a scale of 0 to 10? 10's the worst. And so if they're a 7, 8, 9, or 10, they have moderate to severe pain, right? Now, what if they have 25 out of 10? They will. Somebody will have 25 out of 10. It's still 10 out of 10. Just let them say 25. That's okay. Yeah. Somebody will say that. I've had it, and it happens everywhere. It's okay. Treat them like they have a 10. You can't chart a 25. You can re-educate the patient, and so I could ask you a question about that. It doesn't seem like a very good question, but I could ask you a question about that. Your patient says they have a 25 out of 10. What do you do? Re-educate. So re-educate your patient. It may be that it's a sign to take it very seriously. So if you have somebody who's got chest pain and they have a 10 out of 10, treat it very seriously, or 25 out of 10, treat it very seriously. If anyone ever looks at you and says, I feel like I'm going to die. At one time I said to the patient, you'll be okay. Guess what happened to that patient? They died. Do not tell people they'll be okay. You don't know that. You don't know that. Tell them, I will take care of you to the best of my abilities.
Can't help it.
That's a lot of guilt. I still know that woman's face in my head. It's been 20 years. I feel very guilty. Don't tell them that it will be okay. Okay? So take it very seriously. What was the key to that awful story was believe your patient. And anytime your patient says they're going to die, usually they know it. They do. Take it very seriously. Call a rapid response or whatever your else thing is at your hospital. Okay, so opioids, back to them. They bind to those opioid receptors. These cause sedation of the central nervous system. That's great, right? Oh, I don't want to do this yet. Let's see if my little pencil thing works. Oh, man. I'm practicing writing on my little iPad thingy. Okay, so morphine causes decreased central nervous system effects. So what does that actually look like for your patient? When you're assessing them, what does decreased central nervous system look like? Yay, decreased respiratory rate. What else? Oh, man. There we go. Not exactly.
No.
What causes decreased blood pressure? It blunts the baroreceptor reflex. Okay, so this is a separate thing, this hypotension, right? Because it's blunting that baroreceptor reflex. Let's go back to decreased central nervous system effects. What else? If you stimulate your central nervous system, what do you do? If you take speed, what does your brain do? Right? If you're pretty agitated, you're pretty wired, you're pretty awake. So what if you're not taking speed and you're doing the opposite? You're pretty sleepy. You're sleepy, you're drowsy. You're not thinking straight. Right? So what do you have to teach your patient if they are taking an opiate then? No driving, don't get in the car. No alcohol or anything else that's going to decrease the central nervous system. So alcohol is a CNS depressant. So don't drink with it. Don't take other drugs. So if you're also taking an anti-anxiety drug, for instance, maybe you don't want to take that with a central nervous system drug because you have decreased you'll have increased sedation, decreased respiratory rate. What's the worst thing that can happen if your respiratory rate goes down? Okay. What's the next worst thing? So respiratory depression. So what's the definition of respiratory depression? Yeah. Less than 12 breaths per minute. If your patient has less than 12 breaths per minute, it's an emergency. You can do a couple of things. The first thing I might do is stimulate them. Annie, are you okay? Are you okay? Physically touch them, shake them a little bit. That usually wakes people up. If it doesn't, then you can do a sharp pain, where it's kind of like a knuckles on the sternum kind of thing. That hurts. That'll wake them up. That doesn't wake them up, you're in pretty big trouble, right? So then you have to think about, what am I going to do? I have an airway that's not supported because they're not breathing. So what do? We can give them oxygen. Get help. Think about an airway. So if I stop breathing, what will you do for me? You can do CPR and ventilate me a little bit. You're thinking about those worst case scenarios. You give morphine every day in the hospital. But sometimes that morphine has that bad effect where the patient stops breathing. You need to have a plan. And as the nurse, that's your entire job, is anticipating the worst thing and being prepared to take care of it. So you're like a Boy Scout. What's the Girl Scout motto? It's not be prepared. That's Boy Scouts, right?
Be extra prepared.
Were you a Boy Scout?
I was just saying boys rule, girls rule.
Oh, no. Oh, no. Okay, so make sure you're prepared to provide airway support. You could do that by a bag valve mask, which is the ambu bag. You could just do a head tilt chin lift and keep their airway open. But have a plan. What is it going to be? Okay, so what if they have hypotension related to this blunting of the baroreceptor reflex? So with the baroreceptor reflex, what would normally happen is when you have vasodilation, your heart rate would increase, and then blood pressure would be okay. In this case, there's some vasodilation, but heart rate doesn't increase. All right, so I have a big dilated vascular system. How can you bring my blood pressure back up?
Increase the fluids?
Yes. We're going to give IV fluids. IV fluids. I love that answer. That's perfect. So what does that tell you? If someone's taking morphine, you should have a really good IV or two. Right? That's what the nurse is going to look at. Thinking to yourself, when you're assessing your patient, oh, I'm giving morphine. You might need another IV. That's just one. It's in your hand. It's not a very good space. I'm going to give you a bigger IV so that if you get hypotensive, I can give you a lot of fluid fast. That might be what your nurse is thinking.
How does that help?
So it fills up the vascular space to bring blood pressure up.
Oh, okay.
For the temporary help. Yep. So it's not a full fix, but it will help us get through this so we maintain perfusion to the brain and vital organs.
So is that like a protocol in place, or if that was happening, you'd have to be like, oh, doctor, can I put IV fluids in?
Yes, if this was actually happening in real life, you'd need an order, but you would call what's called a rapid response, which is like a pre-code. It's not a code blue, it's almost a code blue. And the team that shows up can order that. Or if you work in the ER, you probably just have fluid hanging and do it yourself. Because there's autonomy in the ER. Does anybody work in the ER? No. There's just some autonomy in the ER where you do things and then get an order later. But if you're on the regular hospital floor, you call rapid response. And we want you to call early. So if you ever are a student in a hospital and you've got the gut feeling that something's wrong, call for the rapid response and have somebody there. Okay? Even if you're a student.
What fluids would you give, and how does that increase blood
Okay, so you're going to give a colloidal solution like normal saline. We'll give normal saline. It's a isotonic solution. It's basically going to fill up that vascular space. What happened? Oh, no. Getting recorded. So what we could say is that it's important to understand that some people will have diminished response and need more pain medicine without being judgmental to them. So we're looking at each individual and that individual variation. That's the only way that I can use this information right now, right? Make sense to you? So if you're given morphine IV, the onset of action, 7 minutes. So when are you going to reassess your patient? Yeah. So what do? Here's what happens. If I have somebody and I'm giving them morphine IV, I put a blood pressure cuff on their arm. And I set the blood pressure cuff to take every 5 minutes. And then I come back in 5 minutes, or I stay with them 5 minutes, whichever it needs to be. And when it cycles through, I record that blood pressure. I stay with them 5 more minutes, take their blood pressure again, heart rate again, make sure they're okay, have those things done. Okay, so I want you guys to always think if you're giving IV pain medicines, you're getting full vital signs. Okay, blood pressure is so important. Respiratory rate's important in this case. What should you get in addition to respiratory rate? O2 sat. Yeah, let's get that with it. So I have in mind, I'm envisioning my patient in the stretcher, and I have my cardiac monitor, and I've got wires all over him, and he's all wired up, right? And so the temptation is the patient's all wired up to all this stuff, and I have the heart rate on the monitor and all the numbers on the monitor. But remember, even though I told you to do all those things, you're assessing that patient and not the monitor. The monitor gives you some data. But I was really sick one time and had a surgery that went really rotten and was in the ICU and had to have like 6 units of blood because they cut an artery. Pissed me off. It really did. It pissed me off. I was like...
You have one job.
Exactly. If it pulses, you don't put a scalpel to it. I'm just saying. So when I was very sick in the ICU, the nurses and the techs, some of them were great and some of them were just doing their job. But so the ones that were just doing their job, they never even looked at me in my little bed. They'd come over and they'd press that button and they'd write their stuff down and they'd walk back out and I'd be like, hello, I'm a person in a bed. So make sure you're looking at your people because it pisses them off if you don't. I can let you know it really did make me mad. You just want to be very respectful. And also, your patient can tell you a lot of things the monitor can't tell you. The monitor could be wrong, right? Maybe the blood pressure cuff wasn't put on right and it's reading incorrectly. So you can't depend on that, okay? I'm off on a tangent, I know, but I do that. So respiratory depression. If your patient's got respirations less than what? 12. It's an emergent situation. What drug could you give if they were having morphine-induced respiratory depression? Naloxone, right? Your opioid antagonist. You do need an order for that. So if I give you a question about that on a test, it won't say what will you order, right? It will say what will you administer. And if it says what will you administer, it implies there is an order, okay? All right? So be really careful about that role of a nurse when you're reading your test questions. We talked about orthostatic hypotension and how we treat it, but what would you say to your patient?
To change position slowly.
Change position slowly, but so let's move the patient to the hospital. That was great teaching for outside of the hospital and still good for inside, but we need more because we're in the hospital. Right? Are they in a familiar environment? Is there anything they could trip over? Are they hooked to an IV pump maybe? They're high risk for falls, right? And they're in a weird environment. They don't even have their clothes. We put them all in the same gown. And they have to carry this IV pump with them. So what should they do before they get up to go to the bathroom?
Call a nurse.
Okay, so let's have them instructed to call the nurse. Or the tech, whoever, somebody to help them. So that's the teaching you tell them. You make them a high alert. So you put a wristband on for high risk for falls. Or they put yellow socks on them to make sure we know they're high risk anywhere they are. It's like code, right? So sedation is a big problem. You want to let your patient's family know that they might be very sedated, so they're not worried about them. What else might you want to tell your patient about sedation? So on the outpatient, don't operate heavy machinery. On the inpatient, you're doing that same teaching, right? You're high risk for falls. I don't want you to get hurt. Ring your call bell. I'm happy to help you. That kind of thing. Neurotoxicity can occur. A lot of this neurotoxicity can occur with anyone, but especially the elderly who are very sensitive to narcotics. So if I say opiates, opioids, morphine, narcotics, I'm kind of saying the same thing in different words, okay? Y'all get that? Okay, if I'm saying words you don't remember, just stop me. If I get too fast, just stop me, okay? So patients who are likely to become neurotoxic are those who have other concomitant illness. So people who have renal failure, if they're already cognitively impaired, if they have some other effect going on, when you give them morphine, you just increase that risk. So what's the nurse going to do? How will you know if you have neurotoxicity? Okay, so how would you know if their mental status was altered?
I mean, they're angry and upset for no reason. They're, agitated, fighting you. They're just really out of it. Can't answer basic, what's your name? What day is it?
Okay, good. So when they're not acting like themselves, then you're going to ask them the basic questions. What is your name? What is your birthday? Where are you? Do you know why you're here? Maybe they're fighting you, Physical injury happens to nurses a lot because of agitated patients. So you need to assess for it. Your patient's on morphine. It should be on kind of your radar. When I'm giving morphine, I'm going to look for neurotoxicity. And if you notice neurotoxicity, you notify your physician. They'll probably order IV fluids and maybe tell you not to give the dose for a while and let the patient kind of mellow out some. Okay? Make sense? So this adverse drug reaction of constipation doesn't sound like a big deal until you have opioid-induced constipation. And apparently it's one of the worst pains people experience, and some people would rather not take morphine if they have to have opioid-induced constipation. It's that bad, okay? It decreases intestinal contractions, that kind of thing. So what do? Patients who take morphine, they're high risk for falls, but to counteract the effects of the constipation issue, activity helps that, right? So it's like you have to find that fine line between over-sedated and okay enough to go for a walk. So they shouldn't stay in the bed all the time. They should get up and walk, get up to the chair, making sure they're getting some GI workout going on. But they have to do it when they're safe. So you need to know, if I gave morphine at 2 o'clock, or we'll give it at 3 o'clock, it's 3:35, could you get your patient up now and take them for a walk? What's the onset? 7 minutes. How long does it last? 4 or 5 hours, right? So how would you know if it was okay? Assess the patient. Right? And if you look at let's look at your patient. Do they seem alert? Do they seem safe? Take their vital signs. Are their vital signs okay? Is the blood pressure okay? Sit them up on the side of the bed. If they get dizzy just sitting on the side of the bed, lay them down. If they're not dizzy, stand them up. So a lot of it's common sense kind of things that you would do anyway for anybody. But now you're thinking about it very deliberately and making a plan. Urinary retention and hesitancy. Well, I talked about urinary retention already when we talked about some of our other drugs, so I feel like you know what to do with that. Make sure you assess for it. If you ever have a patient who has had surgery and they've had a narcotic and they're going to be discharged the same day, like their outpatient surgery, they always need to urinate before they go home. Always urinate before you go home. Because what could happen is, if they don't urinate before they go home, they could go home and never urinate. and come back in really having a lot of pain, a lot of urinary distension, right? And then you have to catheterize them and send them back home later. So let's just get them up, walk to the bathroom, encourage them to use the restroom. Make sure they can go before you send them home. So important. When I was a charge nurse, I had it happen 2 times where one of the outpatient surgery nurses let a patient go home without urinating, and they had to come back just to get catheterized. Okay, so we can prevent it, so let's try to do that. So morphine causes nausea. It affects the chemoreceptor trigger zone in the brain. So we need to think about that to your patient, with your patient. When you're getting ready to give morphine, already have a plan. You know it causes nausea, so what are you going to do? Yeah, so you might have an emesis base in there. You might have a cool washcloth on their forehead. Those nursing kinds of things. You also might look at their medication record and see if they also have an antiemetic ordered and have it and give it at the same time. Right? So you could give morphine with Zofran to prevent the nausea from happening. Your patients would appreciate that. Sometimes you don't have it ordered, and after you give it, you do your nursing things, and they still have a lot of nausea and start vomiting. So you may have to call the physician and get something ordered, okay, and treat that. But if you can think about it ahead of time and ask your patient, have you ever had morphine? Have you responded to morphine in the past? If they say they do fine without nausea, maybe try them. If they've said, I've never taken it, maybe try them. But if they said, I vomit every time I get morphine, let's put something on board with them. So Zofran works on that chemoreceptor zone to block it. Cough suppression occurs with all opiates or opioids. So codeine is something people take for cough. There's something called Hycotus, which has hydromorphone in it, which is a form, like a synthetic form of morphine. All of those work to decrease cough by suppressing the medulla. So you're actually just decreasing the normal physiologic response. What's the trouble with decreasing the normal physiologic response? Maybe I don't cough. Maybe I get mucus and secretions down in my lungs. Maybe I get pneumonia because I haven't been coughing. So your patient's at high risk. So look at your patient. If they're very old, if they're very sick, think about what you need to do before you give them a cough suppressant, okay? So what are you going to teach them? So if you have a patient who, let's say your patient had an abdominal surgery and they're like 75 years old and really skinny and kind of weak. We call that cachectic, right? So if they look like that and they're developing a cough and you want to give them something for cough, before you do that, you probably want to teach them, even though we're giving you something for cough, I want you to actively cough every hour. I want you to try to cough something up every hour so that secretions don't get stuck in your lungs, so that you don't get pneumonia. Okay, really important thing to teach your patient. We call it turn, cough, and deep breathe. So all of our surgical patients, we want them to move or turn. We want them to cough. We want them to deep breathe every hour. Make sense? So biliary colic is when you have spasms of the biliary tract or the common bile duct, causes a lot of pain. And so if you have someone who's got nausea and vomiting and a lot of pain, and you think it might be gallbladder, which is what the biliary duct goes to, then you want to avoid morphine. We give them another pain reliever like Demerol or meperidine. Okay? If you give them morphine and their pain gets worse, that might be an indicator that they have biliary colic. You might call the physician and order something else. Never, ever give morphine to a patient with a head injury. A patient has got a risk for increased intracranial pressure or has definitely got increased intracranial pressure. It increases the pressure in the brain, and you don't want to cause more neurologic damage. So I could give you a patient who was in a motor vehicle accident, and they hit their forehead on the steering wheel and on the windshield. And they came in complaining of a lot of head pain and knee pain because their knees kind of pushed up against the dashboard. The doctor orders 4 milligrams of morphine. Do you give it? Do you question it, right? Okay, I want you to be able to question that. It's not safe. Okay, so you need to know this toxicity triad: coma, respiratory depression, and pinpoint pupils. That's a sign that you're overdosed on narcotics. So I gave you morphine, for instance, and I walk into the room, and I can't wake you up. You're laying there. I'm like, Annie, are you okay? No response. I check for breathing. Oh, you're breathing a little bit. I pull up your eyelids and I look at your pupils. Are they dilated or are they pinpoint? I call for help. Usually a button at the top of the bed. Call for help. Get an emergency response team there. Or if you're at home, call 911, right? You can't do it by yourself. These are emergent situations.
What do you mean by pinpoint pupils?
So yeah, just very tiny.
Really tiny.
So pupils go from 10 millimeters down to 0 millimeters. So, and we're talking like a 1 millimeter kind of pupil. Literally like the tip of your pen. That big. Okay. So what is the nurse going to do? Okay, so you've called for help. Your patient's got this triad going on. They're in a coma. And you've pressed the button and you called for help. Now what do? I've had nurses get so wrapped up in the moment that they can't think. It happens to all of us. And they've called for help, but they haven't started helping the airway yet. So I really want you to help with airway. You maybe sit your patient up if they're still breathing. If they're not breathing, lay them down and do a head tilt chin lift and open up their actual airway. Get ready to give them oxygen, the bag valve mask. Have some emergency thoughts in your head. I have to be anticipating this. I have to be preventing this. Nothing worse than walking into a room where the patient's coding and the nurse is not doing anything. Okay, happens. Shouldn't happen. So you all know the treatment for this, right? The opioid antagonist. I've driven that, I think. That's Narcan. Narcan needs to be used judiciously. So remember, if you give it, you want to titrate the dose. And when we say titrate dose, we mean give a little bit at a time while you're assessing effect. That's what titrate means. Because you want to wake them up without having the Narcan take over all of the receptors. Because if the Narcan takes over all the receptors, you have no pain relief. So they're having intense pain. And then you just have to wait for the Narcan to wear off before you can give them pain medicine again. So this has happened a couple times. Patients who have overdosed come in, arrested, and we give them Narcan in the ER. When that Narcan hits them, they come off the table and very violent. Because suddenly they're awake and suddenly they're in pain, and it's really traumatic to them. Okay, so you kind of want to do it slowly. The other main narcotic we'll talk about is oxycodone. This is a kind of a moderate to strong. So somebody who's got a pain level of, say, between 4 and 7, oxycodone might be something you want to give. The brand name might be Percocet if you give it, it's got acetaminophen in it. It comes in extended release. So that can be a problem for patients who might have overdosed. You'd be very careful with that. So you're teaching your patients not to open up those extended release pills, causing accidental overdose or something like that. These drugs have a high risk for abuse. Do you have a question?
Do they only come in extended?
No, not only, but they also.
Okay.
Yeah. They come in normal release and extended release. So make sure you're teaching your patients depending on what they have. You want to. These drugs have an potential for abuse, and so typically patients who have pain are not at risk for that. And for your general patient who's having acute pain, you want to assure them that their risk of becoming addicted or dependent on the drug is very low. Some patients will not take pain medicine because they're worried about the risk, but it's actually very low. If they have a genetic predisposition, other people in their family who has some history of drug abuse, they might want to just acknowledge that and monitor themselves, but we still want to treat their pain. It's when you get into chronic pain relief that you might have to worry about the addiction piece or the tolerance piece. And that's going to depend on your patient. So we'll do some assessment with our patient. Some of the things that we do to make sure that drugs aren't abused is to give them a 30-day prescription at a time, right? So every 30 days they'd have to come back and get the new prescription if they still had pain.
Do you avoid any kind of opioid for recovering addicts?
You probably should. A lot of people who are recovering addicts might be on a pain contract with a pain clinic, in which case they are actually instructed not to go anywhere else to get their pain medicine. Okay, so then we don't have a huge risk for that except if they're in an accident or something.
Okay.
And then their accident and their acute injury overrides the pain contract.
Did you say that these kind of drugs have a high risk for abuse or a low risk?
A high risk for abuse. They cause some euphoria. They can be used to help manufacture other illegal drugs. And so we will give them limited amounts just to make sure that we decrease that risk. Enough that we can control their pain, have them keep coming back every month for reassessment to make sure they still need it. Okay, so drug therapy. We've talked all this about opioids, but there's also other kinds of drug therapy that we can do. There's the non-opioids. We'll talk about tramadol, which is a centrally acting non-opioid analgesic. You've probably already talked about Tylenol. You've probably already talked about ibuprofen, right? Naproxen, those COX inhibitors. Those are your non-opioid NSAID drugs. You want to use these things in conjunction so that you get the anti-inflammatory effect along with the pain medicine or the opioid effect. So for instance, if your patient has acute injury like an ankle fracture, giving them oxycodone or hydrocodone might be a great treatment for the nociceptive pain. But if we also give them an NSAID with it, such as ibuprofen or naproxen, we decrease swelling at the site, decrease inflammation at the site, and they recover faster. So when we give somebody an NSAID with their opioid, it's not just to give them more pain relief, it's actually to decrease that inflammation. Okay, so understand that. Sometimes we have pain syndromes that for some reason is not responding to typical opioid treatment. So then we're going to up the dose. So we'll give them opioids for acute pain. If that's not working, opioids and NSAIDs. If that's not working, maybe we'll give opioids, NSAIDs, and these adjuvant therapies like the tricyclic antidepressants. We're not always real sure how they work to help pain relief, but they work together synergistically. Okay, so let's talk about elderly people, and then I'll let you go because you're getting to the time. So with elderly people, you need to be careful with the amount of pain medicine you give them because you want to look at renal impairment and hepatic impairment along with the normal response to aging where you have decreased protein stores and increased fat stores in the body. So they may need an adjusted lower dose. They may respond in a stronger way, having more serious side effects and adverse reactions. So if you have an elderly patient, maybe they're going to be higher risk for having respiratory depression and hypotension than, say, a very healthy 30-year-old patient who just has the ankle fracture, right? Okay. What's the other main reason why they're high risk for adverse effects? Multiple medications and multiple health conditions, right? So they're taking a lot of different medications.